Thank you, Mr. Chairman, for your kind introduction. Good morning, ladies and gentlemen. This is Chjun Chhol Park from Yonsei University. My today's topic is novel approach to hemostasis in non-variceal opportunistic bleeding. I have no disclosure. This is my content of today's presentation. First, I'm going to short introduction for non-variceal opportunistic bleeding and endoscope management, and I'm going to show several kind of novel tools for using new materials, and I'm going to share my data about the efficacy of a hemostatic powder. So non-variceal opportunistic bleeding is a common medical condition which continues to yield significant healthcare burden, and peptic ulcer bleeding remains the most common cause of opportunistic bleeding. In the past 20 to 30 years, decreasing trend in the incidence rates of admissions and mortality associated with peptic ulcer disease due to decline parallel decrease in Helicobacter pylori associated peptic ulcer disease, and reduction in the complication might be associated with the widespread use of anti-secretory drugs. However, the risk of patients with peptic ulcer bleeding has significantly increased because of the aging population with multiple comorbidities or the increasing use of aspirin and NSAID. Over the past 20 years, admission for peptic ulcer bleeding have declined steadily worldwide, but the case of fertility rate remains stable at 5 to 10%. But there's still the cautious for higher for weekend admission or higher for public holiday admission. Let's talk about endoscope hemostasis. So failure of endoscope hemostasis usually 8 to 15% by conventional method, and rebleeding of opportunistic bleeding is observed like 10 to 25%. And most of the source of bleeding is a duodenal bleeding or gastric also bleeding. And as you know, the fourth classification most used for making the risk stratification for ulcer bleeding. So we usually mention that stigmata of a recent hemorrhage of peptic ulcer bleeding, like major SRH, is a Forest 1A spurting, or 1B oozing, or 2A, the non-bleeding visible vessel. So this kind of categories represent a very high risk of rebleeding groups. So that makes sense that rebleeding rate of opportunistic bleeding is observed 10 to 25%. And also there are some factors associated with difficulty in hemostasis, like patient with chronic illness, ESRD, or liver disease, or ischemic cardiomyopathy. That kind of patient has very high rate of bleeding tendency, and most of them are taking new anticoagulation or antiplatelet agents. And in Korea or Japan, there's more growing cases that evolving the more large size of early gastric cancer that makes more difficult to prevention hemostasis. And I'm going to move on to the next topic for endoscope management for using our novel tools. Based on the traditional hemostasis method, there's several novel tools for using new materials for hemostasis. The first is a Doppler endoscope probe, which is exactly not a hemostasis method, but if we use this kind of a probe, we can manage more detail for managing for bleeder. And second is over the scope clip. This is very this clip has a more powerful for compared to a conventional clip. And another modality is a hemostatic powder, which was developed 5 years ago, and now there are some increasing study for evaluating this kind of a hemostatic powder for hemostasis. So first, a Doppler endoscope probe. This study was published in 3 or 4 years ago in gastroenterology. It's a prospective RCH trial. So enrolled 148 patients with severe opportunistic bleeding. The they divide two groups using the Doppler versus traditionally visually guided endoscopic therapy based on SRH. So as you can see the result, the Doppler group has a more even lower rate of rebleeding rate because we can target in more detail for using the Doppler group. And second is OTS clips, which are more effective than standard endoscopic therapy for recurrent bleeding of peptic ulcers. The first multicenter study is published 4 years ago that totally 180 patients and primary and secondary hemostasis for upper GI bleeding, and 92.4% success in initial hemostasis and 78 with no rebleeding during admissions. And second prospective RCT multicenter trial was published in Gastroenterology, which is endoscopically confirmed rebleeding from peptic ulcer within 7 days after initial successful hemostasis. And you can see that the OTS group had a more significant, very low further bleeding rate compared to the standard therapy group. And third, a novel modality is a Hemostatic Powder. There's two representative company, which one of them is a Hemospray manufactured by Coop, which is widely used in European country. And second is EndoClot. This kind of a powder is also available in Korea right now. And another two company from Korea company, first is the Next Powder, and second is Bio. So this Hemospray we cannot use in Korea right now. So I have experience about EndoClot and Bio Gel. So mechanism of action of hemostatic powder is similar between according to the company, even if the composition is a little bit different. So the mechanism is rapidly absorb water from the blood, causing a high concentration of a platelet RBC and coagulation protein that accelerate the physiologic clotting cascade. And the instant interaction of a particle rapidly produces a gel matrix that adheres to and seals the bleeding tissue. There are several advantages of hemostatic powder, which is non-thermal and non-contact, and also non-traumatic, similar characters. And the final is a non-specific targeting. So, in summarize this kind of a characteristic, we can summarize that this kind of a hemostatic modality requires very minimal technical expertise to use in comparison with conventional therapy. In the early phase study about hemostatic powder, the most of study started with Hemospray. An initial study was published in the same year, 2016, at the endoscopy and the GI endoscopy. And first study is a multicenter study, and they present that the very good result, immediate efficacy rate like 96%. But the early rebleeding rate is 38%, which is quite high. Another GI endoscopy study also shows similar result, like initial hemostasis rate is 100%, but the rebleeding rate is 25%. So in the initial phase study, the study conclude that the initial efficacy is very good, but the rebleeding rate should be confirmed by a more large size or randomized controlled trial. After all the studies, recently two meta-analysis was published about hemostatic powder, and this meta-analysis include upper GI bleeding and lower GI bleeding. They include 19 studies over 800 patients, and all study was using the Hemospray. And the clinical success rate is 92%, and early rebleeding rate is 20%. And they also show that monotherapy versus combination with conventional therapy, there's no statistical difference. And this meta-analysis also show that the similar clinical outcome compared to previous meta-analysis. And this study shows almost 84% was used by hemospray studies, and 3 studies were RCT, and immediate hemostasis rate was 95%, and success rate in spurting bleeding also is a very good result, over 90%. And similar efficacy as compared to conventional therapy, and 7-day rebleeding rate is almost 18%, and bleeding late mortality rate was at 1.4%. So from now on, I'm going to show some clinical experience about Hemostatic Powder in our institution. This study is a first study perform Hemostatic Powder for handling upper GI bleeding in Korea, and I designed this study for a prospective study, but not randomized controlled trial. So I collect the 40 patients with upper GI bleeding treated with powder, and I compare with conventional therapy with over 300 patients. As you know, when we perform the upper GI bleeding study, there's many bias can affect it. So I try to handle this kind of bias, so using the propensity score matching according to GB score. This is baseline patient characteristics. So bleeding origin is most of them was peptic also bleeding, and GB score is a significant difference between the 2 groups. But after matching, there's no difference between the 2 groups according to GB score. So according to Forest classification, both before and after matching, there is a significant difference. And usually Forest 1A, 1B, like more high rate of a rebleeding group, has more dominant in a powder group. And the final result show that both before and after matching, there's no difference between the 2 groups, like immediate hemostasis rate around the 97% versus 90%. And also 7-day rebleeding has no significant difference between 2 groups. But the 30-day rebleeding has a significant difference between 2 groups, like powder is a more low rate, but I don't pay attention to this result because this is not a prospective RCT trial, and there's still affecting the bias even if we control the GB score. So in summary, even though most recent studies were small sample size, all studies demonstrate that the possibility of a hemostatic powder in the management of non-varus upper GI bleeding. But however, the impact of using as a monotherapy has not been fully evaluated yet, and prospect study is still very scarce right now. So therefore, the more large group and prospective comparative studies would be needed to confirm these results. So therefore, after previous study, we designed a prospective multicenter randomized controlled trial to evaluate the efficacy of a hemostatic powder compared to the conventional method based on injection therapy. So this study primary outcome is immediate hemostasis, and secondary outcome is rebleeding rate and safety and comparison of difficulty. And total enrolled patient was 234 patients. This is the final result of the prospective multi-center RCT trial. This data was not published yet. And as you can see, there is no big difference between the conventional powder group and conventional therapy group. And all the Rockwell score, GB score, or AIM-65 scores, no difference. And the half of them were the duodenum, and rest of them usually stomach bleeding. And there's some difference between the 2 groups, like Forest classification. And as you can, there's a very interesting result that we evaluate the difficulty for management of using powder or conventional therapy, and we we divided a non-expert versus expert. In non-expert group, the powder group has more seems more difficult, but expert group, the conventional therapy is more difficult. So that means usually the non-expert group, there is a very non-familiar with using hemostatic powder. So I think there's some learning curve, but in the expert group, they have many experience of managing a hemostasis. So that makes sense that the powder is very easy to use compared to the clipping, something very specific modality. So, and also the procedure time shows that the non-expert group has a more longer time in powder group, but there's no difference between the expert group. So this table shows the primary outcome. Immediate hemostasis success rate is no difference between the two groups, like 87%. And also there's no difference between two groups, like failure of initial hemostasis also, but except for S2A. So 2A group it's not an active bleeding group, but when we're doing some therapy like clipping or coagulation, like 2A lesion, that can make a change to the spurting or oozing pattern. So that's why the hemostatic powder, like non-contact method, has a high rate of success rate of a 2A group. And the rebleeding rate also there is no difference between two groups, like 7.5% versus 8.8%. And also there's no difference between according to the Forest classification. This study, the result of this study is very meaningful in clinical field, that this is a prospective OCT trial using very large sample size. So I think we can use this kind of evidence that the powder has is a non-inferior to compared to conventional therapy based on injection method. And lastly, I'm going to introduce some different study using hemostatic powder in preventing bleeding after gastric yeast in high-risk patient. As you know, these days the risk factor for post bleeding is very increasing because of an antithrombotic agent, and more large section are known as a strong risk factor for post bleeding. So some studies show that patient with continuing antithrombotic therapy during the procedure, there is a bleeding rate can up to 57%. Therefore, I'm going to show the efficacy of a hemostatic powder in preventing the post bleeding in high-risk patient, because the powder is relatively easy to use compared to the shield method or the suturing method. So this is a single center prospective study. The endpoint was secondary endoscopy and rebleeding rate. As you can see, the 44 patient was finally analyzed, and the bleeding within 4 weeks were 9%. Group 1 is a large sections group, and group 2 is an antithrombotic therapy group. I have a limitation time, so I'm going to quick review this study. So most of the powder group has there's no only rebleeding, 0%. Most of them were bleeding event was over 10 days. So that's I realized that there's some possibility of prevention of the only post bleeding in using the hemostatic powder. Based on our study, this study is the first prospective study to use the powder of patients who undergo ESD. We can see the possibility, but the further randomized controlled trial should be needed to confirm this efficacy. So we designed prospective multicenter randomized controlled trial to evaluate the hemostatic powder to preventing post-bleeding in high-risk patient, and this study was published last year at Endoscopy. And also this study shows the possibility that the powder can prevent post-it bleeding in large resection site. In summary, recent years, new topical hemostatic modality have been introduced to allow for easier and effective hemostasis. OTS clip may become one of the promising care for treatment for severe recurrent peptic ulcer bleeding. There is limited comparative evidence of efficacy of hemostatic powder in clinical practice, but based on our prospective multicenter RCT, promising outcome on initial hemostasis after application of hemostatic powder can be achieved. But the rate of rebleeding and the performance of active spurting bleeding should be needed for further study. Thank you for your attention.